Hi, this is Brian Kim. I'd like to share with you a case of secondary IOL with pupilloplasty. This is a 20-year-old gentleman who was hit by a BB gun in the right eye 2 years ago. He developed a traumatic cataract, which he had removed, but then his medicaid expired, and when it was time for a secondary IOL placement, no one seemed to want to take care of this gentleman. So he not only had aphakia, he also had a traumatic mydriasis, and this is the pupil, and he did not receive any dilating drops. And this patient came in with a hand motion vision, but I saw that his post-operative note showed that he was correctable to 20/20 after his cataract surgery. So I felt fairly optimistic that we could help him. I'm using a multimin to retract the iris pupil edge to see if the zonules were intact and to make sure that there's a adequate ciliary sulcus without any fibrosis. And so it seemed like things looked pretty good. I went ahead and made my temporal incision and decided to use the I&A handpiece to see if I could remove these lens epithelial cells, these Elschnig pearls. And lo and behold, these little cells started to evacuate fairly easily. The polymer tip really helps me to be confident and bring that port right up to the posterior capsule and remove these cells without any problems. And so as I'm removing the cells, I'm trying to determine what my next steps are. You could see that these cells come off fairly easily. And I'm going to also try to get underneath. You can see nasally there is an anterior capsule edge there with some fibrosis, and I was able to get underneath that. And you could also see that little crescent-shaped fibrotic anterior capsule probably needed to be removed because it's fairly central, and so I'm using these long Van Ness scissors to cut the fibrotic anterior capsule edge, and I'm using some forceps to try to peel that off. But as you could tell, there's fibrosis on the other side, and so I go ahead and use an intraocular scissor to cut and amputate that piece of anterior capsule. So then I reinspect here just to confirm that there is adequate sulcus and adequate zonules. There is no posterior capsule tear. There is no propagation of the anterior capsule tear posteriorly. And while I was evacuating those lens epithelial cells, I could tell that the posterior capsule was pretty strong, and there was no fluctuation or movement of the posterior capsule. So it tells me that the zonules are also fairly strong. And so I go ahead and put in this 3-piece acrylic lens into the ciliary sulcus. And I'm going to rotate those haptics so they're superior and inferior like that. And I'm removing the viscoelastic, and the lens was very stable. At this point, because the patient's young and I didn't want to cause any trampolining of the anterior chamber, I'm injecting Mycol in the anterior chamber while I have irrigation on. And then I'm going to go ahead and inject some viscoelastic in the anterior chamber, and then remove the I&A handpiece. Again, for young patients where the vitreous is formed and less tolerant of intraocular pressure fluctuations, I like to try to maintain the pressure as much as possible. I'm starting the baseball stitch in order to close and make the pupil smaller. I'm going at 2x speed here just because watching this can be fairly painful, but I'm doing a running baseball stitch with a 10-0 prolene suture on a CIF4 needle. And I'm going to go ahead and externalize the needle by docking it through a BSS cannula. And I'm going to go through this, I'm going to do a pupil closure from 3 points. This is a double armed suture, and so from the same starting point, I'm going to go ahead and use the other needle to do the baseball running stitch on the other side. And again, this is fairly painful to watch. So I'm going at 2x speed, but you want to try to not cheat. You want to try to lasso and loop as many times as possible. The more you do the loops, the less distorted the pupil will be. And so I'm going to go ahead and use a needle again to pass it through the lumen of the BSS cannula so I can pull it out of the main incision. And then at this point, I'm going to rotate the microscope. You see I'm coming from the temporal position there. I'm going to rotate the microscope. So now I'm actually sitting superiorly. And using that same needle, I'm going to go ahead and thread the rest of the last 1/3 of the pupil. And again, the running baseball suture technique. And this needle will then be externalized through the same paracentesis where my first needle was externalized. And so both suture ends will be externalized from the same paracentesis, which will allow me to tie the suture and close it. So again, there's no elegant way to do this. You just kind of have to do the best you can and try not to do any large movements as you do this, and try to be as atraumatic as possible with these maneuvers. Just gently you want to tease as you pull the suture out. So I'm going to go ahead and tie. The key is not to tie it too tightly, because if you do, the pupil is going to be way too small. So you want to put a little bit of slack as you tie it. And so this pupil is much smaller than before. As you saw pre-op, or at the beginning of the case, the pupil was very large. Now it's much smaller at about 4 millimeters. It is round, but you can see there's some irregularities to the edge. But on a macro level, this is less obvious. This patient, before surgery, was hand motions and was very discouraged because no one would do his surgery. After surgery, this young man ended up with 20/30 uncorrected vision. This was his pupil 2 weeks postoperatively, and this is how he looked 2 weeks postoperatively. He was ecstatic after surgery, had a big smile on his face, and I'm glad we were able to take care of him. Thank you so much for your attention.